Okay, now we have third exhibit, value for money. Value for money, we know that it is three E's: economy, efficiency, and effectiveness, which is used by not-for-profit organization for performance assessment. Now, PHS is formulating a new strategy to redirect resources from poorly performing hospitals to those which are performing well. In order to improve EHS overall performance, the board is particularly keen to improve survival rates. Board is particularly keen to improve survival rates in patients who suffer a type of serious medical emergency known locally by doctors as a type 3 serious medical emergency, or just T3. T3s are more a common cause of death in Eastland, and there is significant political and public pressure to improve survival rate to match international standard. So T3 is a common cause of death in Eastland. There are two other significant factors in addition to the treatment which patient receives at hospital, which affect their chance of survival after T3, which affect their chance of survival after T3. The length of time it takes to arrive at a hospital, usually by ambulance. So the lead time is important here. How much time ambulance will take following our T3. Other risk factors related to their medical history of a patient, lifestyle, and overall state of health. These factors are used to identify patients who are classified as high risk and who have much lower survival rates than T3 patients as a whole. Other patients who are not classified as high risk are classified as normal risk. EHS has defined the survival rate as the proportion of patients who are still alive 30 days after suffering a T3. EHS new strategy is to use three E's, economy, efficiency, effectiveness model, to assess hospitals according to their value for money and then consider redirecting resources according to this assessment. The board has asked you for a value for money assessment of hospital A, B, and C using the performance data and additional background information supplied in Appendix 2. In conclusion to your assessment, you are required to advise the board on the appropriateness of its strategy to redirect resources away from the worst performing hospital. Now we have Appendix 2, performance data for hospital A, B, and C for the year ended 31st August 20x5. A, B, and C, number of patients admitted to hospital following a T3 due to this disease, which is a common cause in T-land, in 10,000 in hospital A, 6,000 in B, and 5,800 in C. So if we add up, it is like I think 21,800. Number of patients alive 30 days after a T3, 4,900 patients. Then we have 3120, and then we have 3480. So within after 30 days, with alive 30 days after T3. So those who have T3, their lifespan is like 30 days. So 11,500 alive for 30 days after T3. Number of doctors employed to T3 patients 50, 25, and 20. So we can say that 95. Total salaries are like 7,500 plus 2,750 plus 2,000. So we have 12,250. And number of patients, proportion of patients classified as high risk. High risk patients were 60% in hospital A, 45% in hospital B, and 30% in hospital C. Proportion of patients classified as high risk. So it's a quite risky disease. If we look at the different measures, like if we look at this, we are saying that those who could survive, like 11,500 divided by the total admitted patients. So we can say that 52.75% patients could survive for 30 days. Then we have like number of doctors employed to treat T3 patients. We have 95 doctors and served how many patients? 11,500. If we look separately for each hospital, 4,900 divided by, in fact, rather 4,900, first we should divide it by the total, like 10,000 divided by 50 doctors, then 6,000 divided by 25, 5,800 divided by 20. So 10,000 is 200, 6,000 divided by 25, 240, 290. So 4,900 divided by 50, and here we have 174. Let me check the second one. 3120 divided by 20, it's 124.8. It is 98. So doctors are very low in comparison with the patients. Although we don't have any benchmark for the comparison, but we can say that that this number is quite high. That 174 patients for one doctor, 125 patients almost for one doctor, even 98 patients for one doctor. Here we can calculate cost for each doctor as well, like 7,500 divided by 50, 2,750 divided by 25. Then we will calculate cost for each patient as well. So if we say like 7,500 divided by 50, it is $150. If we have 2,750 by 25, it is $110. If we have 2,000 divided by 20, it is $100. Then we have 7,500 divided by 4,900 patients who can survive. It is 7,500,000. So I will say 7.5 million. You can say it's not 150, it is 150,000, 110,000, and we have like 100,000. Similarly, 7.5 million divided by 4,900. Here we have 130 per patient, almost 131. Then we have 2,750 divided by 3,120. Those who can survive, it's like 2,750,000. 881. Then we have 2 million divided by 3,480. It is 574, almost we can say 575. If we divide this cost by total patients, like 7.5 million divided by 10,000, then what is the cost? 750 per patient. Then we have 2,750,000 divided by 6,000. Why are we doing all these calculations? Because no targets are given, and for the not for profit seeking organization, we will use these measures to assess the performance or resource allocation. Secondary, we don't have any data for comparison which can help us to evaluate either we are paying better appropriate cost to patients or we are paying not. Although question told us that EHS hospitals are not performing well in comparison with the neighboring countries. So 3,480,000 divided by 5,800, it is 600. So now we will look at the requirement of the question, value for money. Now we will look at the answer that assessment of hospital A, B, and C using the three E's. Calculation for each measure are shown in working one. First of all, we will look at the working one because we also calculated number of values while reading the question, and almost they also did the same. Salary per doctor, we also determined that salary per doctor is like here we have 150,000, 110,000, 100,000. So this is the salary per doctor. Patient treated per doctor is like what 200 patients are treated by each doctor. We also determined these values, although we only took these values that those who get well. But if we divide 10, yes, 200, 240, 290, we also determined those values. As I told you while reading the question that this data is provided to uh, calculate these measures because it's a not-for-profit seeking organization, so there are no specific ratios. Survival rates, you can calculate survival rates. We calculated survival rates as a whole, 52.75. Individual is 4,900 by 10,000, it's 49%. Similarly, the next one, 3,120 divided by 6,000 is like 52%. And the third one is like 3,480 divided by 5,800 is 60%. Economy means obtaining key resources of an appropriate quality at the lowest possible cost. Doctors are the key resources in the data given. Hospital A pays the highest average salary per doctor, which is like this 150,000. Highest average salary per doctor, and the hospital B and C are comparable, which perhaps reflect their status as general hospital and their locations. Hospital A salary cost might be expected, however, as doctor there are highly qualified specialists in treatment of T3. Highly qualified specialists in treatment of T3. They may simply be paid a higher salary to reflect their higher level of skills, qualification, and experience. So if we look at the patients, they are serving like 98 patients, and if we look at the like survival rate of the patients in this hospital A, sorry, in the working A is 49%. On the other hand, where salary is low, their survival rate of the patients is high, and they are serving the lowest possible patients, and the others are serving highest number of patients. Second one is efficiency. Efficiency means obtaining as much output as possible. So these two measures which I mentioned to you, these are relevant with the efficiency. Much output, obtaining much output as possible at the required standard relative to the input. Number of patients treated per doctor is a simple measure of efficiency. Number of patients measured served by each doctor. Hospital A has the lowest average number of patients per doctor and the salary is highest. This result may be expected as higher risk patient probably take longer to treat. Doctor at hospital A spent time treating specialist or T3 doctor, which may reduce the time available for treating patient. Hospital T has the best result for the efficiency measure, but it also has the lowest percentage of patient classified as high risk. It is simple measure and ignore whether the treatment is of required standard. Though there are likely to be regulatory and professional safeguards to ensure that this is the case. So, though there are likely to be regulatory and professional safeguards to ensure that this is the case, the measure of efficiency also ignores the use of other important resources such as nurses and other healthcare professionals, as well as equipment and other facilities. There may be a regional differences in how quickly ambulances get patient to hospitals, which is a further complication affecting patient survival rates. So third one is effectiveness. Effectiveness means ensuring that output achieve the organization's objectives. Objectives are not clearly mentioned that in terms of percentage that survival rate must be 60%, must be 70%, and it is difficult to obtain in such type of industry, especially hospital, where it is not possible for a human or doctor to control the life of a patient. They can try on their best, but definitely it is in the nature's control. It is out of the doctor's control. In this case, the focus is T3 survival rate. Focus is as much as we can provide better treatment to the patients for the improvement. Hospital A has the worst performance in this area because it has the lowest T3 survival rate, but this could be expected as the proportion of high risk patients and have lower overall survival rates, in much higher than other hospitals. This is a limited analysis of effectiveness. It is narrowed one objective and does not address the quality of teaching, quality of life, treatment of other emergency and non-emergency medical conditions, all of which are relevant to the hospitals. Overall advice on the strategy. Hospital A appears to be worst performing and bearing highest possible cost in the trial based on all the three measures. According to the new strategy being formulated by the board, resources would be directed away from hospital A and they should be given to hospital B and C, especially C, where salary is the lowest, patient treatment per doctor is highest, and survival rate is highest. The board strategy seems simplistic, however, as directing the measure resources away from hospital A may reduce survival rate in high risk patients who comprise the highest proportion of T3 patients treated there. An alternative strategy might be to direct resources towards the worst performing hospital in order to improve their performance. Direct the resources towards the worst performing in order to improve their performance. Directing resources away from A may also limit improvement in both T3 survival rate in the future and the quality of life of surviving T3 patient. This is because training and development of new treatment of T3 which takes place in hospital A. So he is saying that rather than putting out the resources, it can worse the performance. It is better to provide them better training and development so that they will be able to save the lives of their patients.